Okay, we're going to move right along to our next one. We'll have Dr. Ricardo Yamada from MUSC. And he's going to be talking about bleeding associated with pancreatic disease, traditional and endovascular techniques. This is something that we have a long history of at MUSC. I was going back, one of our early interventionalists, Ivan Vujic, published on this topic in the 1980s, and I think we keep revisiting it. And it's actually one of the major areas that we encounter bleeding because pancreatic disease has so many ways that the blood vessels can get messed up. So we'll see what's going on in modern times. Dr. Yamada?
Well, good morning, everybody. Thanks for being here in this cold morning. I'd like to thank the organization for the kind invitation to be part of this program. I'm going to be discussing about some considerations regarding traditional versus endovascular treatment for bleeding associated with pancreatic disease. So I have no disclosures. When talking about bleeding from the pancreas, there are basically three major problems: pancreatitis, tumoral, and also vascular anomalies. Most of the times those anomalies are related to HHT syndrome, but by far the most common cause of pancreatic bleeding is related to pancreatitis, either chronic or acute. So we're going to be focused on our discussion on that particular topic. In the setting of pancreatitis, the pathophysiology of the bleeding is basically related to the amount of inflammation around the pancreas. That inflammation will lead to arterial wall erosion, which will lead also to acute struvization or pseudoaneurysm formation. On the other hand, the amount of inflammation can also lead to splenic vein thrombosis, and that thrombosis will lead to varices, and those varices can also bleed. So we can have an arterial or a venous source of bleeding in the setting of pancreatitis. Regardless of the source of the bleeding, the patient can present with hypotension, abdominal pain, GI bleed, or combination of those. So in the setting of variceal bleeding due to splenic vein thrombosis, the treatment, the definitive treatment is still splenectomy. But last Thursday, we were able to see a very nice presentation on BRTO, which is an endovascular alternative to treat this type of patient, especially the more complex one. This is a technique that we can embolize the varices coming from the jugular vein or the femoral or even transhepatic, and then we can able to achieve hemostasis in more with less morbidity and mortality to those complex cases. We also need to keep in mind that even for splenic vein thrombosis prior splenectomy, embolization of the splenic artery has been used with very successful results. And this is a paper that was published by a group of surgeons in China where they compared patients that underwent splenectomy with embolization and without embolization prior to the surgery. So what they found was that the group that had embolization prior to splenectomy had a reduced operative time, had less blood loss, and also they were discharged faster than the group that did not have the embolization prior to the surgery. So it has been very helpful, especially for laparoscopic splenectomy. So in order to embolize the splenic artery pre-op, we usually can use 3 different types of devices. Sometimes we start the procedure with PVA. Sorry. So we use PVA to achieve first distal embolization of the vessels. And then we can, after getting distal occlusion, we can use either coils or the M-Platz plug to perform a proximal embolization, just like a surgical ligation. So this is an example, the patient, big spleen. This was, we put a catheter, this in the splenic vein, we're able to embolize with PVA first, and then occlude the distal vessels. And in the end, we were able to put some coils there and then doing the proximal embolization. So other example, in this case, we use a plug device to occlude the proximal splenic artery. You can see that for that, we need to use a bigger device, a bigger sheath, and then if you have a more tortuous anatomy, that might be the best device to be used. Sometimes a coil with a microcatheter is easier to be deployed, but when you have a straight anatomy, you can use easily a vascular plug and can achieve hemostasis pretty quickly. Also, we can also use for splenic vein embolization, we can use cover stents. We're going to talk later on about that, but also can be a device that can be applied for this type of lesions. So when we're seeing arterial bleeding, the surgical options are basically limited to open ligation or pancreatic resection. But as you can imagine, those procedures are associated with more morbid mortality, and the results are not the best. So embolization in this setting is definitely the first option. So every time an arterial bleeding is the problem, we need to look for embolization first. And there's also a paper that showed the compare multiple type of modalities to treat pseudoaneurysm, and then as you can see, embolization was the one associated with the less mortality. Some surgical options were associated with higher mortality, up to 22%, as shown by this paper. Most common arteries associated with bleeding in the setting of pancreatitis are the splenic artery, the GDA, and the pancreatic duodenal artery. This is an example of a case. Again, you can see patient with chronic pancreatitis, a lot of calcification in the pancreas, a big pseudoaneurysm, and a big pseudocyst and bleeding into the pseudocyst. The patient was brought to the angio room, able to get a catheter there, and then you can see impressive amount of active contrast extravasation. Sorry for the fast movie. So we're able to embolize the splenic artery with coils, and important to note is that the embolization was done also distal to the point of extravasation. That is important to mention in order to avoid back bleeding from collaterals distal to the point of extravasation. Okay. So this is another example of, again, patient with chronic pancreatitis, pseudocyst treated with cystogastrostomy. You can see the communication here. She was having a ERCP when she started bleeding acutely. So the GI colleague called us asking for help. So the patient was brought directly to our room, hypotensive, a lot of bunch of bags of blood hanging. So we did the first celiac trunk injection. We didn't see much signs of acute extravasation. We saw some blush of the pancreatic parenchyma related to the inflammation. We went more selective, even though we couldn't see a point of active bleeding. The GI guy was with us in the room, and he said, well, we put it in a clip to at least try to stop the bleeding and also try to guide you guys to the point that was the problem. But as you can see, there were a bunch of clips all over the place, and then he said, well, but he said, okay, I'm pretty much sure that the clip that I used was that one. I said, okay, let's see what we can do. So having said that, we went selective in this small branch here, and then with a microcatheter, and then we injected, and then we could see a big blush, a big sign of contrast extravasation. So, and because the catheter was here, we could not go further than that. We decided to use glue in order to embolize. So you can see the glue distal here, some glue inside some small branches. So the patient became normal tensive. When we were able to take the patient out of the room, he was recovered fine. So there's a last example. Again, patient with chronic pancreatitis, pseudocyst. They also showed in the MR a concerning lesion for pseudoaneurysm around the lesion next to the lesser gastric curvature. And although I mentioned that the most common arteries are the splenic, GDA, and pancreatic duodenal, this was an injection in the left gastric artery, and that injection we could see that rounded lesion consistent with the pseudoaneurysm seen by MR. So we're able to get a catheter, microcatheter, selectively, drop some coils, and that is the completion angiogram. You don't see the filling of the lesion anymore. So the patient didn't have any bleeding after that. So just to conclude, in the setting of arterial bleeding, the endovascular treatment is definitely the first option. There's no question about that. We can achieve hemostasis faster with less morbidity and mortality. In the setting of variceal bleeding, splenectomy is still the definitive treatment. But as I mentioned, we need to keep in mind that BRTO is becoming more and more an attractive alternative to treat more complex cases. And also, always keep in mind that prior to splenectomy, arterial embolization of the splenic artery can lead to less blood loss, reduced operative time, and faster patient recovery. Thank you.